Another poster presentation for you now that's caught our eye, and introducing here is Chris Walton. Chris Walton is from Hull in the UK. Chris, tell us about your poster.
Our poster, it's a poster I'm representing the Association of British Clinical Diabetologists, which is the specialist association in the UK. And our specialist association does real-world audits on drugs recently brought into the UK. Now, one agent which is widely used is an injectable treatment called liraglutide, which can help with diabetes control and weight control. But what we're also interested in is the effect on the risk of things like heart attacks, stroke, and death. And what we've done is to use a modelling technique on the data collected from around the UK to look at the effect of liraglutide on what we call cardiovascular risk.
And what were your findings?
Well, the audit database was around 6,900 patients collected from about 167 centres throughout the UK. On 747 patients, we had complete data which allowed entry into what we call the UKPDS risk engine, which is an acronym which stands. UKPDS was a landmark study in the UK.
And we've had a presentation here.
Indeed, it's quite famous. And there's a risk engine derived from that which allows you to model cardiovascular risk. And the bottom line was what it showed was that over 10 years, using liraglutide, based on the data in the audit, there was a reduction of 3 cardiovascular events, mostly heart attacks rather than strokes, and over 2, to be exact, 2.4 deaths. Now, in terms of the numbers of people needed to treat with liraglutide to prevent 1 death, you're looking at 42 people needing to be treated to prevent 1 death, or 33 people to be treated to prevent a heart attack or stroke. And that's comparable with many other treatments which are widely accepted as being valuable.
So was this event result a surprising one, or better or worse than you expected?
It's really probably quite similar to what we might have expected. In scientific trials, what we call double-blind trials, like the LEADER study, the effects are even greater, but patients were recruited to the LEADER study who already had cardiovascular disease, therefore they were a very high risk.
So in a highly selected randomised control group, you're obviously seeing a great effect,
yes.
But it's actually reassuring that you're seeing in real-world evidence at least, if not as great, then certainly a comparable effect.
I agree entirely, and particularly as this group in the real world, they're a much fatter group, body mass index 38 compared with the LEADER study of 32. I'm afraid the UK really is the fat man of Europe in terms of the BMI of its diabetic populations.
Terrific. Okay, so very reassuring data there from the UK, and if you want to see that poster, you can see it on EASD.org.